One of the most common problems of heart failure with reserved ejection fraction and mildly reduced ejection fraction is exercise intolerance. So what is exercise intolerance? It is defined as a complex clinical syndrome represented with reduced oxygen consumption or VO2 during physiological stimulation. Oxygen consumption will be affected by cardiovascular, pulmonary, and muscle structure and function. The table shows some methods to diagnose exercise intolerance, such as NYHA functional classification, ECG stress testing, 6-minute walk test, and cardiopulmonary exercise test, with their advantages and disadvantages. Of these, the 6-minute walk test is a simple and most commonly used objectively assessment method in clinical practice, while cardiopulmonary exercise test is the most comprehensive test to measure exercise capacity, but it takes more time and is expensive. In 6-minute walk test, patients are instructed to cover the maximum distance possible in 6 minutes at a self-graded walking speed and pausing to rest when needed. 6-minute walk tests provide information about the distance, patient's exertion, and the adaptation of their cardiopulmonary system during and after the test. The patients with 6-minute walking distance less than 300 meters will have high risk of mortality. Cardiopulmonary exercise test is a comprehensive test combines exercise with measurements of various physiological parameters such as heart rate, blood pressure, oxygen consumption, carbon dioxide production, respiratory rate, ventilation, and electrical activities of the heart. The work rate will be incremental, and the peak oxygen consumption is determined as the highest oxygen consumption achieved when patients reach maximum effort during the test. Peak oxygen consumption is considered normal when it is equal or greater than 85% of the predicted value, or greater than 20 millimeter per kilogram per minute, and abnormal when it is less than 85%. The evidence of exercise intolerance in patients with heart failure with preserved ejection fraction is shown in this figure. You can see that the average of peak oxygen consumption is around 15 millimeter per kilogram per minute, which is below the normal range. In addition, many activities of daily living such as dressing, making bed, or walking that are trivial for healthy adults to perform but require near maximum if effort for patients with heart failure with preserved ejection fraction. Let's take a look deeper in the pathophysiological abnormalities contribute to the clinical manifestation of heart failure with preserved ejection fraction. Risk factors such as comorbidities, aging, obesity, physical inactivities, and systemic inflammation lead, lead to downstream of multi-organ dysfunction, frailty, and cardiac dysfunction, and skeletal muscle myopathy, resulting in inspiratory muscle weakness and exercise intolerance. Indeed, the peak oxygen consumption could be reduced by 35% in patients with heart failure with preserved ejection fraction, compared with healthy age and sex-matched control subjects.